Hi, my name is Anna Yeung, and I'm presenting today on clinician and community preferences for bacterial STI testing interventions among men who have sex with men, an Delphi study in Toronto. I'm presenting today on behalf of the HIV CBR Catalyst Grant team. This is a study that's led by Dr. Anne Burchell at St. Michael's Hospital. I'd like to acknowledge the contributions of our study participants, as well as our peer recruiter who was based at ACT, Amir Bachari. This study was funded by a CIHR HIV community-based Catalyst Grant and a CIHR Foundation Award. We declare no conflicts of interest. The rationale for this study is that gay, bisexual, and other men who have sex with men who are living with or at risk for HIV experience higher rates of bacterial STIs, specifically chlamydia, gonorrhea, and syphilis. Testing rates remain below the recommended levels set out in Canadian guidelines, and we need some kind of innovation to increase testing. More frequent screening leads to earlier detection, treatment, and disrupts transmission. The objective of this study is to build consensus regarding the interventions with the greatest potential for GBM in Toronto from the perspectives of the community members and providers. To be eligible for this study, you had to be, as a community expert, you had to identify as a man who lives in Toronto, be over 18 years of age, and had to have been sexually active with another man and had tried to get or gotten a bacterial STI test in the past 18 months. Men were recruited via social media, targeted emails, Grindr ads, and posters at gay spaces. A total of 51 men consented, and 46 completed the first round, and 43 completed all 3 rounds. And this took place between October to December 2019. For provider experts, they had to have offered STI testing to GBM in the last 12 months within their clinical practice in Toronto. They were recruited via targeted emails. We had a total of 48 who consented, 45 who completed round 1, and 37 who completed all 3 rounds between February to May 2020. We had a total of 8 interventions, and these were subdivided into 3 major categories. The first 2 categories, streamlining STI testing for asymptomatic individuals and client-targeted STI testing interventions, were shown to the community panel. The provider panel saw a 3rd set of interventions that were aimed at them. For a Delphi panel, this is where you have groups of experts, and you ask them to rate how much of a priority for GBM, how much of a priority is a proposed intervention for GBM in Toronto. We asked them to rate it on a 7-point Likert scale, from definitely not a priority to definitely a priority. In the second round, we summarize those responses from the first round, show them the distribution and summarize the open text comments, and then we ask them to reprioritize. If they disagree with the majority, we ask them why. In the third round, we do the same thing where we summarize the previous round's responses and then ask them to prioritize one final time. This allows us to identify areas of consensus and remaining disagreement. For the purpose of this study, consensus is defined as 60% or more who indicate a preference within 2 adjacent responses. So for our community experts, we had a total of 43 at the end of round 3, and the majority of them were aged under 40 years. Most of them identified as gay. Over half identified as a racial or ethnic identity other than white, and 19% reported that they were HIV positive, 37% were HIV negative on PrEP, and 42% HIV negative not on PrEP. And this actually lines up quite well with what we see here in Toronto. We had a total of 37 provider experts. The majority were aged under 40 years. Most identified as male, most were physicians, and most were practicing in primary care. This was a highly experienced group in sexual health. Over half saw at least 20 GBM per week, and 70% conducted 20 or more bacterial STI tests per month. So for our first category of interventions, streamlining STI testing for asymptomatic individuals, what I've shown you here in this table is the summary of responses at the final round. So community experts are there in the middle, provider experts are on the right. And then each panel is subdivided into their overall priority. So not a priority, neutral, and a priority. For online-based testing, this is where you would complete your risk assessment online. download your lab requisition forms, and go directly to the lab. For those of you who are familiar with the Get Checked Online model in British Columbia, this is based off of that. For express testing, this is where you would be able to go to the clinic, but rather than having to see a provider, you could self-collect your own samples and drop them off. For nurse-led testing, you would go to the clinic and a nurse would help you complete your risk assessment and collect your samples. For routine testing, this is when you would be offered an STI test at your regular checkup. So as you can see here, for both community experts and provider experts, we reached consensus on all 4 interventions. I do want to draw your attention to the first 3 interventions for provider experts, the online, express, and nurse-led testing, because between round 1 and round 2, we saw almost a near unanimous switch to about 100% prioritization for these 3 interventions. Now, round 2 took place about 2 weeks into our first COVID lockdown back in March 2020. And so we think this might reflect how people felt about the delivery of healthcare at the time. For our second group of interventions, client-targeted testing interventions, again, I've shown you the summary of responses. So for client reminders, this is where you would receive a reminder to come in for your STI test, either via email, SMS, text message, or snail mail letter. And then we also showed them the intervention, the online booking app. So this is where you'd be able to complete your risk assessment online and be able to book at a clinic near you. So again, we reached consensus for the community experts and the provider experts. I do want to draw your attention to the client reminders for community experts. This was the highest rated prioritization among all the interventions that were shown to the community experts. For our last set of interventions that were aimed at the provider, I've switched it up a little bit, and I've shown you the responses from round 1 versus round 3. So for provider alerts, this is where you would get a pop-up alert when the provider opens up the client file and lets them know that this person is eligible for an STI test. For provider audit and feedback, this is where the provider would essentially receive a report card on how many tests they've done. So at the beginning of round 1, for both provider alerts and audit and feedback, you can see that almost half of the respondents said that both interventions were a priority. However, by the time we get to round 3, we see a shift towards not a priority and neutral. So for community experts, the top 3 priorities were client reminders, express, and routine testing. For them, testing should be convenient, quick, easy, and private. However, they really valued the provider relationship. They liked the rapport that they had established with their current provider, and they wanted access to non-stigmatized care. Testing for them should be accessible, integrated, and normalized into everyday life. For provider experts, their top 3 priorities were express, online-based, and nurse-led testing. I believe this reflects a shift away from the primary provider, possibly because they want to decrease the burden on existing services. However, it was identified that you need funding and support for all of the interventions presented, and there were questions of how do you manage follow-up? Who is responsible for something like a positive test? There were also concerns about potentially increasing their workload and not having enough capacity within the clinic. So as you can see, there is enthusiasm for innovation within STI testing. The community preferred interventions that favored convenience and access to the provider, whereas the providers preferred interventions that emphasized patient independence and manageable workloads. So there really wasn't a one-size-fits-all solution, but what if we took the elements of each intervention that people liked? Like leveraging technology from the online options, that's something we'd like to investigate next. Ultimately, the best intervention is one that decreases barriers and increases access. Thank you very much.